Oh,
Hi,
please.
Jeff. You sound great.
It works.
You, yeah, you sound just fine. How are you today?
I'm doing pretty well, and you?
I likewise, I'm doing well.
All right, I'll unmute again. Sean, are you on? Bill? Kimberly, I see you.
Good afternoon.
Good afternoon. JJ?
Hello.
Okay. So I think we have enough, don't we, Margaret?
We do, and I think I'm looking at the list. I think Sean just jumped on as well. I think he joined right after you called his name. So yeah, I think we have all five work group members present.
Okay, I will call to order the Innovation Work Group meeting on October 18th. Our first order of agenda, as always, is approval of the prior meeting's minutes or synopsis. Do we have a motion?
JJ, so moved.
Thank you. Second.
This is Kimberly. I'll second the motion to accept the minutes as presented.
Great, thank you. All in favor?
Aye.
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 Great, okay. So the next thing up is a report on value-based payments. And it's Summer from the Health Authority.
Hi, excuse me. I'm recovering from COVID and I'll try to not have to cough too many times. Yes, Summer Boswell with the Oregon Health Authority. I'm with the Transformation Center. Margaret, are you going to advance the slides? You've got them up, I guess, right?
Yeah, I was going to say Rose typically can advance them for you if you just want to give her a cue when you're ready.
That's great. Thank you.
Yeah, you bet.
Perfect. So I know you have heard about and are familiar with the VBP Compact. So there's a little bit of background information I'll go over pretty quickly. So we can spend more time diving into the details of where the 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 work group has come out with their roadmap, and so describing the strategies in the roadmap, and then some where we are in terms of timeline, and actually specifically around the development of the primary care VBP model, and a toolkit to advance VBP across the state and across all care delivered. Next slide, please. I think you all are familiar with this. Just drawing your attention to what you know is that when we're talking about these advanced value-based payment, when we're talking about the compacts and the targets in the VBP compact, they are 4 categories, 3 and 4. Next slide. And looking at where we are in Oregon with data, both you can see within PEB and OEB as well as other markets. The most recent data we have is from 2020 from the All Payer All Claims database, and you'll see that where we are for category 3 and 4, and then so totaling those up, PEB OEB is at 48%. 49% for commercial. Both of those are, as you know, Kaiser does play kind of an outsized role when we're looking at this kind of information, and that's both in commercial and in PEB and OEB. The CCOs are at 39% and Medicare Advantage is at 38%. So there is VBP happening across all markets, and there's definitely opportunities for to increase what type of VBP is, sort of moving up in level of sophistication, as well as increasing VBP, any type of VBP being used. Next slide, please. So the VBP compact first emerged as the first cost containment and mitigation strategy that was identified by the Cost Growth Target Implementation Committee. While the compact supports achievement of the sustainable cost growth target, the cost growth target is not the emphasis of the compact. Increasing the use of VBP is the emphasis. So the targets driving the work of the compact work group are adoption of VBP and the goals and the targets around that adoption. But they are related. Next slide. So the compact is, as you know, it's a voluntary commitment by payers and providers focused on lowering the rate of cost growth, fostering health equity, and improving quality and outcomes. The principles, it includes principles that set the VBP targets, center equity, and are focused on those advanced VBP models in land categories 3 and 4. Next slide, please. You'll see in the targets are and you that the model, the requirements and the target set are not specifically for prospective budget-based payment models, but that is where the intention is as much as that is possible when it is feasible to have prospective budget-based and quality-linked payment models, that's what should be used. There are specific details of the principles that outline expectations that advanced VBP models should be designed to promote health equity, as well as to mitigate adverse impacts on populations experiencing health inequities. And those include design features and measures to protect against stinting, ensuring that prospective payments are sufficient to cover the cost of the infrastructure changes that are often needed to support health equity, such as integrating traditional health workers, having the data systems or changing data systems to be able to track equity and report on equity. Providing the additional supports such as technical assistance or infrastructure payments that for providers that are serving populations experiencing health inequities and really need that additional assistance to be able to meet the needs of all of their patients. That ensuring the new, particularly upside and or downside risk models will not exacerbate existing inequities. And that ensuring providers serving populations experiencing those health inequities who are at greater risk of closure due to COVID-19 remain open. And then the principles include specific VBP targets. And next slide. There. So here are the targets and there's two sets of targets. The first one is for all care that's provided, and that's to reach a LAN 3A, so that's shared savings or higher, about 35% in 2021, 50% in 2022, and on up to 70% in 2024. And then for primary care payments and to acute care hospitals, that there is a separate target that is shared risk or higher at 25% in 2022, getting us up to 70% in 2024. And just to in comparison back to what I showed you from APAC, which is data from 2020, we are at like, so for PEB and OEB, you're at 48% for in 2020 for all for that first target of all payments, LAN 3A or higher. We haven't been able, don't have the data yet to be able to differentiate enough for the hospital payments to be able to provide data, a status update of on that the second target that's specific to primary care and acute care hospitals, but we hope to have that. We will have that data with the 2021 APAC data, which will be available in January. Next slide, please. So there's been 47 signatories covering 73% of Oregonians. There is much room to increase the number of signatories, particularly among hospitals and clinics. The number of signatories now does include all of the major payers in Oregon. And as we are, now that the roadmap is complete and we'll be doing more work around that it affects hospitals and clinics, that we will be we'll be reaching out to engage them as signatories as well. Next slide. This is the list of signatories. You've got the slide, so I can breeze through that one. But we do have a lot of signatories. But you can see on the right that there are definitely provider organizations, clinics, and health systems. There are many, many more than are listed there, and we're now really ready to start reaching out to folks to engage them more. Next slide, please. So the work group to advance the compact was convened by the Oregon Health Leadership Council and OHA with support from the OMA and the Hospital Association. And it's charged with ensuring the compact is successfully implemented, and identify opportunities to accelerate VBP, articulate the challenges, which I will share in just a minute, or some recommend strategies to address the challenges, support implementation, and monitor and report on progress. Next slide, please. So this is the list. Oh, next slide. We're stuck maybe. Oh, there you go. Great. This is the list of the Compact Work Group membership. And I should have said earlier, Tom Siltabo is one of our members, and we're so happy to have him on the work group. And I hope that, Tom, that you will chime in as we, as I share a little bit more about the work.
I'm never
Okay, next.
shy.
Great. Next slide, please. Oh, great. There we go. So we're the Compact Work Group is back one is working very closely with other efforts and to be in alignment. Okay, sorry. Now you can go to the next one. So these are the main big challenges that the work group identified. Challenge of transitioning from fee for service, that there are multiple VBP models, there justifiable provider concern about financial loss, lack of a data infrastructure. Some larger clinics and health systems have a robust data infrastructure, and many practices do not. There lack of meaningful risk adjustment. Payers have very different ways that they attribute members. That there are a large number of payers, that can result in small populations, both for payers and providers, and then definitely the ongoing repercussions of COVID. So next slide. So here's the more meatier work. So this is the components of the roadmap. So the Compact Work Group identified strategies to overcome the challenges that I just breezed through, and those include these 6 strategies here: a short menu of VBP models, strategies to mitigate financial risk, a VBP toolkit, policy alignment, equity, and attribution. And I will go into each of those in more depth. Next slide, please. So the first strategy is to develop a short menu of VBP models. We know that a challenge is that there are multiple VBP models, and that's a barrier to providers. And it makes the transition from fee for service to VBP even that much more challenging. So having a short menu will hopefully facilitate greater model alignment and adoption. And when we're talking about a short VBP menu, we're talking about one, not just one, but sort of the idea of models focused on primary care, on hospital, and specialty care. And the idea is that for the primary care, they're really focused on developing that it'll be one model. That may be the case with the hospital model as well, and then specialty care models will probably be multiple models, as there are great differences in between different specialty procedures and care. The VBP Compact Work Group has asked the Primary Care Payment Reform Collaborative, which is a multi-stakeholder body that's been convened by OHA per legislation since 2016 and is charged with improving and aligning primary care payment. The work group has charged this collaborative with developing the primary care VBP model, and the work group is coordinating with the Hospital Association right now to set a plan for the development of the hospital model, which we hope to begin next year. And the hope is that the primary care VBP model will be complete this year, although there is quite a lot to work through in terms of decisions, and I'll share a little bit more about where the primary care model is a little bit later in the presentation. And then hoping in next year to at least identify some priority specialty care VBP model priority specialty care episodes, likely for specialty care VBP model. And then we'll be developing and implementing a communication plan to share the menu of models as it rolls out. Next slide, please. So developing a VBP toolkit was a strategy identified by the work group to address the challenges of that shifting from fee for service to VBP. How do you do that? How do you handle and address the possible financial losses, and really how do you step through the process of assessing readiness and to engage in VBP, understanding what VBP models there are, what they look like, what does it mean, and how do you work with your with payers as providers. That the idea, or the main audience for the toolkit will be is providers, but clearly payers want to know and have it be transparent, and providers want payers to know that these are the things that are included in the toolkit, because they're things that providers need and to be able to implement VBP. And so it goes both ways. And that first action step of assessing the status of VBP adoption, that we did do an informal or non-scientific assessment at the end of last year or early this year, and to get kind of a back of an envelope sense of where what VBP implementation looks like, acknowledging that the most recent data we have is based on 2020 from APAC. And the assessment really mirrored what the APAC findings were, that VBP is happening and there's many opportunities to increase and spread. The toolkit will be a virtual toolkit that will cover the foundational elements of VBP, sort of as well as specific models. And there's a subgroup of the compact work group that has been meeting to guide content and design, and I'll go into a little bit more detail on that in a few slides. Next slide, please.
Summer, I'm going to jump in for just a minute.
Yeah.
The issue that should be clear to everyone is the complexity of doing this and the different stage of readiness that the different types of entities, provider entities, there are in the state. So in Portland Metro, where you have dominated by multiple large medical groups, have the infrastructure and the sophistication, the data, and the organization to be able to move quicker than a lot of other smaller entities. So the toolkit, as Summer is describing, is something that will kind of lay out how to do that, and yet the key component is to understand how the primary care entity that's part of, let's say, Legacy Health or the Providence Medical Group is going to be able to do this in advance much differently than the 3-doctor office in Pendleton. And that's just an acknowledgement, and the rules need to be the same, but the expectation around the time it takes to get to these areas is real. And what's been very helpful is that we've had participation from Liz Powers, who's a family practitioner in Enterprise or Joseph. I don't know which of the two, but basically way the hell out in the bush or in the mountains, and yet, telling us the reality in that setting also. So that's been very important. And the same thing, I just talked about medical groups. The same thing is true with capacity at hospitals, because we have some very small hospitals, and then of course we have hospital systems, and we'll see there'll be a different at least time frame for these groups to do it. The question is whether or not we will have to have separate kind of approaches. I'm not sure how that plays out. I'll shut up now.
Oh, thank you, Tom. And I'm realizing I don't have a whole lot of time left. So I'm gonna you've got the slides here. We're really focused on equity and integrating equity in all areas of the work. And there are those, as I mentioned earlier, there were design equity principles that were part of the compact. And we're really looking to implement those. And I'll touch on it again in a second, because it's something that is being integrated now into the primary care VBP model development. Next slide. In terms of mitigating financial risk, really thinking about and exploring, different opportunities. There, be looking at potentially risk corridors, population size, and risk adjustment. There is beginning the primary care VBP model development group is talking about social risk adjustment tomorrow. I know that there's a lot of interest in that, and so I think more to come. But these tools will be integrated into the toolkit. Next slide. Data and policy alignment. Working closely with. Oops. Next slide, please. Working closely with OHIT and High Talk to make sure that we are leveraging and developing data components that for the toolkit that will help providers be ready to participate in VBP contracts. Oh, you can stay there. Yep. So, and the final strategy is around attribution, and that knowing that it's a challenge, but providers have to know who their patients are to be able to provide good care. There was a set of principles that were developed by the Primary Care Payment Reform Collaborative that to have payers and providers encourage and facilitate patient choice of a PCP. That payers, providers, and patients should work collaboratively to ensure accuracy of that attribution, and that where it's not possible, where there is not a patient selection of a PCP, that payers should prioritize primary care visits when they're using claims or encounter data for attribution. There's some other principles, but those are some of the key ones. Yeah, so let's go to the next slide. Sorry about that. Okay, so here's some of the key action steps. Oh, next slide, please. The key action steps and who's responsible for what. And the VBP Compact work group is overseeing all the work and assuring accountability. And this reflects who's the lead for executing. And so the Primary Care Payment Reform Collaborative, which is on the far right on the top, is developing the primary care model. The OHLC and the Hospital Association will be working on the hospital model. And you can see that the toolkit is pretty much, everybody's working on that. So those are the pieces there. One piece I didn't cover in the policy alignment is that the last listed here is making the compact targets required for OHA lines of business. I know that that's already in the works with OEB and PEB, and it's planned for the next round of CCO contracts and in conversation about how to do this with them in the marketplace.
I see that Sean has his hand up. Sean?
Thank you.
Yeah, I have a few questions. I can wait until you're wrapped up. I just want to get in the queue, you know?
Okay.
Okay, let me move quickly. So next slide, please. This is the our timeline. Sort of see we're at the end of this year. Oh yeah, hoping to finish the primary care model, launching the hospital specialty later, developing the toolkit building blocks now. And as we finish the VBP, the primary care VBP model, developing that content for the toolkit as well. And that reviewing primary care VBP model for equity impacts across each, or viewing each of the VBP models for equity impacts will happen as the models are in development. If you want to go to slide 25. You can go to the next slide. I'll just give you a little bit of information about the two pieces of work that are really underway right now. So the previous slide, please. Go back one. So the preliminary recommendations for the primary care VBP. That it there's a work group that's been meeting since May that meets monthly to discuss the different aspects of this model. And they've so far decided that it will be a prospective per member per month payment model, so a capitation model. That it will incentivize PCPCH recognition, but not require it. But it will focus on services provided, but not specific provider types. And they're in the process of working through a list of all the procedure codes that are delivered in primary care and deciding which ones would be part of that prospective payment. And that then it could be any, it could be any provider type, whether it's a traditional health worker or, or a nurse or anyone that's providing those services within the primary care practice could be covered within the prospective payment. That there will be a performance-based incentive payment that should both reward high performance relative to a benchmark as well as improvement over time, and that eligible incentive payments must have a minimum value to be impactful. They've actually decided that an incentive payment should be at least 10% of billed payments to have be big enough to make a difference. And so these are some of the decisions they have made over the next few months. They are continuing to talk about incorporating equity, what it would possible medical and social risk adjustment, what those specific value incentives and rewards would be, and what metrics would be used, and how to support providers with their data needs and infrastructure needs. Next slide, please. So here's where we are with the toolkit. As I said, the audience for the toolkit is both providers and payers, although more leaning on the need for providers to have tools. The content's being developed now and will focus on guidance to support implementation and success of VBP in primary care, including core financial and clinical risks. And members have agreed that the toolkit include tools to help providers use data to confirm patient lists with payers and to analyze and produce reports. So you can see that in that first box, they're getting ready for VBP. That's a something that is applicable across VBP models. How do you engage your senior level champions and a team within a clinic? How do you define the value objectives? Considering health equity and social determinants of health risk factors, and then identifying current data analytical capability. And then there's the components around what's the specific to the payment model. So starting with primary care, then implementing VBP with your payers. What is it? How do you work specifically with your payers around attribution, around data, around quality improvement, and overcoming some specific VBP challenges. And these are just 3 examples that the group developing the content for the toolkit has identified so far, but I'm sure there will be more. So there's small patient numbers. What about safety net providers, and then that just the details of and needs of shifting from fee for service to VBP. So I'll stop there. That's there's the next slide is how to stay connected with the work, but we can stop on I'm guessing there'll be questions on the primary care model development or the toolkit.
Okay, Sean, why don't you lead off?
Okay, thanks. Thanks for the presentation. It continues to be an important topic for us, for both boards. Couple questions. My first question is about measurement. And I'm interested in why it seems like we've exclusively decided to measure at adoption based on payments. Because that strikes me as odd, because it's almost like we're measuring it fee for service style for VP. And so ideally in the end, people are in stage 4, in which case the payments per service are sort of beside the point. In fact, where you really want to get to is a situation where the healthier they keep a person, the more money they make, because they can just keep it. Because they had to do less services, or at least less expensive services. So, and it seems to me that the advantage of measuring not the payments, but rather the contracts through which payments are moving. In other words, what percentage of all of the local contracts with all the local providers are under a VP, a value-based payment scheme? That would be the measurement, and you would know that way ahead of time, because you wouldn't have to wait 2 years for time to pass, because they have to have that contract before the year starts. So you'd know ahead of time where they are. And I'm wondering if there's any discussion, not to say like you don't want to track the money. I mean, yeah, I mean, ultimately you want to track the money, but that almost seems like an afterthought to me. I would be more interested in the contracts going forward. How many of them are currently, how many have agreed to take PEB, let's say, all of PEB people through some VP, some value-based payment model. And you can measure that way up front. And so is there any discussion about that strategy, or is there a particular reason why we're measuring like the payments for the services is like the measurement of payments given in a VP value-based payment model? Like, am I missing like a key ingredient here?
Well, I think there's a couple. Well, one is that one thought is that they're that it's the the data that we have, and I think that you get the health plans will report how money is spent, as opposed to sort of the upfront contracts. But also that that if you were just looking at contracts up front, that you wouldn't have the same impact on population health, because you'd only be looking at, you'd only know for, for certain members at each clinic, as opposed to the practices whole patient population. Is that?
So when you're measuring the clinic, you're measuring all of their payments?
This is Sean. This is all the database that they're using for the Oregon's health economy is the all payers, all claims database. That's
right.
The best way of being able to look at it, and it's in a way miraculous that they're able to say how much of that is actually falls into one fee for service versus VPB. A VBP process. So it's just the data that we have, and I understand what you're saying, and I think the end goal is to, once models are created, will be to essentially count, who's in the contract for the value-based payment methodology versus still just fee for service. So that will happen.
I hear you, Tom.
It is what it is.
Okay, hold on a minute. So let me clarify my question. So so let's just take a clinic, right? And we're looking at a like a clinic system in our data from all payers, all claims. Now, PAB is the signatory OHA in this compact, right? Intel is not, right? So Intel is a large, private insurer in the state, right? So is Intel's payments in the total that you gave when you were saying like 30% of this or that? They're in there
commercial market.
based in the commercial market?
Yeah.
Yes.
They are. Okay. Yeah, okay. I guess I would just encourage you to think about an additional measurement. Like I hear you, the strength of this, and certainly you want to follow the money. But like also just knowing like how many insurers are under contracts that are value-based payment models. It seems to me would also be useful to know.
I'd like to question and to be confirmed that Intel's claims is included in this, because A, they're self-insured, and B, they're domiciled out of California. So are we certain that they're included in this data?
That is a good question, and I actually, one of my coworkers is on. I know is on the call, and hoping maybe. Zachary, are you available?
Hi, everyone. I'm here.
Hello.
Hi, everyone. Zachary Goldman, health cost economist at OHA. Is the question, are self-insured lives in APAC's claims?
Yeah, such as Intel, yeah. Mm-hmm.
Such as Intel. So we voluntarily receive some self-insured ERISA data, but not all. Due to the Gobet Supreme Court decision back in 2015, 2016, those data are not compulsory. So entities do not need to send us that data. We do have some, but for sure not all.
That was kind of what I was understanding. And so hence back to my main point. Another way to measure that I feel like would be useful is just to like crack open the contracts and be like, are they in value-based payments or not? Like are the networks themselves agreeing to those terms? Because they would need to know that way ahead of time. because they're either managing people's care for the purposes of keeping them healthy because they're under value-based payments, or they're not. They're expecting to be paid for fees, which means they're chasing sick care. And that's the fundamental shift we're trying to make. And if we're not measuring them that way, we're kind of reinforcing the previous way. You see what I mean? So it's
Love
just,
to chase this down further. We're 15 minutes over at this point. Could we get some response at the next meeting? Where
Yeah.
it's definitive?
That would, yes, definitely. Yeah.
You can do that,
And we
Summer?
can get you a response in writing as well.
That'd be great, because I think that might be even more satisfactory to you, Sean. And,
Yeah,
and
agreed.
me as well. So, well, thank you very much, and hopes for continued getting better for you, Summer.
All right, thank you.
Getting over that. If anybody else has got a question, we can state and ask them to get back to us. Is there one we want to add to Sean's request?
I would just make a comment, Jeff, that, you know, the real challenge PEB and OEB have right now is the hospital cap and getting providers to engage in VBP arrangements, you know, with that hospital cap in place. And I think the intent for the next PEB board meeting and then the one following the next OEB board meeting at the retreats is to talk more about VBPs and how to reach those targets in the future. Because I think I saw 48%. We're not expecting that's going to stay up that high in 2021. Correct me if I'm wrong, Margaret. But
Yeah, I mean, we have heard that COVID has changed the landscape a little bit. I think there's been some pandemic impacts and such. So, you know, I think we don't yet know. Like, for example, for 2022, now we won't know where we are until sometime toward the end of 23. So I think that's, you know, a little bit of the, when you're looking at percent of payments, I mean, that is a little bit of a lagging indicator. You're looking back historically and seeing what you were at last year. So yeah, I think thinking about how we can have indicators that are forward looking as well would help.
Okay. Well, we need to move on and get updates from our carrier partners on their updates. So we're going in alphabetical order. So Kaiser's up first.
Yay. This is Hardesh Lal, and hopefully you guys can see me and hopefully you can hear me.
Yes, on both. You sound great.
Okay,
Thanks.
all right, guys. So yes, again, Hardesh Lal from Kaiser Permanente. I'm Director of Contracting and Finance Officer. Again, Margaret, are you controlling the slides? You can advance to the next slide.
Yeah, Rose is controlling the slides. And just to note, so folks are aware, in this virtual environment, there is about a 5-second delay when she advances the slides. So don't worry if the slide deck's a little bit slow keeping up.
Great, thank you. All right, so again, as we, for Kaiser Permanente, again, maybe it's easier to first explain the model. Again, one thing is that, you know, our mission is to, again, provide high quality, affordable care to our members and the community we serve, right? The one model of Kaiser Permanente, most of you, if you do know, it is a prepaid business, right? You get premiums and you know, there are entities that Kaiser in the health plan side contracts with, so that you know, that is heavily internalized. So meaning that you know, the great thing about this integrated model is that you get prepaid premiums, but you focus on wellness to avoid the illness. And if you focus on wellness because you are prepaid, you know, and heavily internalized, that every claim that you have out there is, you know, if you are managing wellness well, then you avoid illness. And that's how, and that's the model. It's a cost minus system versus a revenue plus system. So what we have in the Kaiser model over here, if you see, is the category 1, which is, again, Kaiser Permanente, you know, is integrated, meaning that the health plan contracts with the KFH, which is Kaiser Foundation Hospital, which is a capitated contract, as well as the medical group, which is a capitated contract. And so the internal, the capitation with our hospital systems and our medical group is in that category 4, which is about 87%. What we call is in category 4. What's in category 1 is that 13.5%, where the health plans have contracted, not in the hospital contract or medical group contract, but these are contracts that health plan owns directly with the providers themselves. So most of the things that fall in here that may not be covered in the capitated arrangements with the hospital or the medical group would be things like if they are generally outpatient services such as lab imaging. If we directly contract for outpatient services with Kaiser Permanente, Kaiser Foundation, not the Foundation Hospital, but Kaiser Health Plan of Northwest, when they contract directly with these outpatient services, it's more of a volume-based contract, right? A claim-based contract that we have with those providers, and those are in category 1. So that's kind of what our spend calculates out to be. Most of that 86 or 87% that we have over there is in medical group and health and hospital, and also as the foundation hospitals and the medical group, as you know, those entities have the service internalized. So meaning we have owned the hospitals, and we own the medical offices and the physicians, and so they are, so that's kind of how the model is set up on the alternative payment model framework. Pause there for if you have any questions, probably before we move to the next slide. So, okay, well, here's what I just spoke. It said, the level of VBP arrangements, again, from the Kaiser Permanente health plan point of view, I mean, there is capitated, obviously the premium comes on a capitated basis, right? You get revenue, mostly premiums on a PMPM basis. So there's a contract with the medical group, which is a capitated contract with built-in incentives. There's a contract with the Kaiser Foundation Hospital, which is a capitated contract, and Kaiser Foundation, then the hospital takes that capitation payment, which they contract, or they most of the time internalize or provide care at our own hospitals. And then the health plan itself then directly contracts for some health plan services, administrative services, or services that may be directly with the providers that are not necessarily physicians or professionals. So, and the capitated arrangements, there are certain, the bigger ones that we directly in the health plan side that contracts directly with the outside providers are things like alternative medicine, which is what I call like chiropractor services, naturopath kind of services fall in that category where we try to contract directly. And it's an alternative form of providing care that is probably more affordable and then a care that's provided, on the illness side. This is more of a wellness side care and alternative care to medicine. And also another big contract we have is for DME services. That is the direct contract with contract with other entities. But those are capitated arrangements. They are fully capitated arrangements with built-in incentives in those contracts. And let's move to the next slide. Again, this is our ongoing strategies. It's ongoing strategies. I will also say not necessarily ongoing, but it's kind of the model of what we do is as we look at some of these some of these contracts that are what we call in the 13-14% range, which are volume or claim-based contracts. We assess whether it would make sense for us to internalize those services and with those services where it makes financial sense and we can maintain the quality and the expertise in the KP world, we would continually look for services or try to see what it would take to internalize those services in our own infrastructure. We continually, again, review contracts and that are, with inflations and see where the types of contract there are, and looking to see if those are contracts that could be, again, managed more on a either prospective payment basis where you are case-based reimbursed, not really line item bill charges reimbursed, or you are on. It could be ideal for you to have a business in a market where you could be more appealing to have a value-based contracts. What we are currently pursuing is, there are areas, as you guys are probably all familiar with this, that during this pandemic, there has been just increased demand in some of the services where the demand for services have really outpaced the providers that are needed to provide those services. And these are mental health type contracts, ABA contracts, rehab, which means physical therapy, occupational therapy, speech therapy, skilled nursing facilities. You all probably hear about this skilled nursing facility and the shortage of beds we have over there where patients, the problem is that if you don't have skilled nursing beds, then patients are sitting in the hospital in a more expensive setting. So these are areas that we currently are actively working with providers to see what could be done to be more on a not necessarily claim-based times environment, but more of either a value-based contract, which is fully capitated, which has difficulty with some of these providers, again, because these are providers that are smaller and unable to take that risk on a value-based contract, but would be more, would be something that we can at least start with contracting with these providers on where heavy payments are paid on quality type payments versus just claim-based payments. So these are some of the focus areas today in the contracting environment that we are looking to see if we can do either a move away from volume type based contracts or into more either quality type reimbursement or a value-based payment type contract, which would be again most appealing. But the difficulty here is, like I said, is smaller providers have more difficult time, trying to get to a value-based contract type arrangements. But I think that's all I had on what we are doing. I only had 10 minutes, so I'll leave some time for questions if you have any. But again, it is what we do. It is heavy. A lot of a huge percent of our business is under value-based. And again, it is the model of Kaiser Permanente where the focus is really to keep members healthy, communities healthy. And as a result, that's a cost minus system that would then that's how the bottom line, I guess, is made with Kaiser Permanente by keeping members healthy.
Questions?
I'm sorry, did somebody have a question? Oh, you were asking if anyone had a question.
Yes. So, okay. With that, we'll pick up some time here. And Moda, you're next.
Hi, everyone. I'm Bill Dwyer, Director of Analytics at Moda. My team focuses on value-based payment in particular. And so I'll walk you guys through some of the slides. I'll just say that there's a lot of slides here. I'm not going to go through them all in the interest of time, but probably hit the first few of them more intensively than the last few. So I think everybody's seen this slide by now, so we're familiar with the land framework. So let's just proceed to the next few slides where I'm going to show some data. So, and this is just to remind everyone what this data represents. It's we do this annually. That lines up with our all payer, all claims database submission. I actually will just take a second and just address the question that Sean Parkman brought up earlier, which is why we measure the dollars. And really just the simple reason that we do that We actually do this by contract. So we could do it even in advance, but the thing is we want to know how big each contract is, and so that's why we wait till the end of the year so that we know what the total dollar value of the contract is. But certainly, I agree with that general sentiment that that a lot of the answer is known well in advance. So, and we'll go to the next slide, and just reminding everyone so that this is calendar year 2021. So here on this slide, I'm showing the OEB payment categories, and what we decided to do here is break this into a coordinated care model versus non-coordinated care model. And so in our coordinated care model is some of the OEB members and all the PEB members. And so the non-CCM would just be those OEB members only that are not in our coordinated care model. And so you can see the stark difference there, and that was by design. And so in the coordinated care model, we have the biggest portion of this falls into category 3A, where we have a upside-only shared savings model that provides the vast majority of our providers an incentive for controlling the total cost of care for their members. The reason that we have a lot of dollars in category 1 are that, number one, we do have some members that still don't have a PCP assigned. That's for various reasons. Sometimes their PCP leaves the network. Sometimes they enroll and they just haven't selected. I mean, there's a bunch of reasons why small handfuls of members here and there will not get a PCP. And then, of course, also the non-CCM members in general do not have a PCP assigned. Often these can be people who, some of them are younger and healthier people who just don't regularly go. Sometimes it's people that just said, you know what, I don't want to say who my PCP is. And so they have a hang up with that, and that's why they're in the plan that they're in. But that's why a lot of the dollars are still in category 1. We believe that the dollars in category 3A is going to continue to increase because of migration to the coordinated care model plan. So we just moved a substantial number of members into that plan this year. So next year that the dollars in 3A is going to keep going up. We also have introduced a new behavioral health value-based payment model. So that's going to increase dollars flowing into 3A. And I see that there's already a question.
Yeah,
go ahead.
Bill, just a quick, just to make sure, we're talking primary care services here, correct? We're not talking hospital, and we're not talking specialty care.
This chart that I'm showing represents all OEB and PEB dollars, not just primary care dollars. And
okay.
So,
Thank you.
and to explain what I mean by that, so we have, so if you, to give you a specific example of how this works, there are providers that are probably never going to be in a value-based payment arrangement, but that does not mean that you cannot influence the utilization of that in a value-based way. And the simplest example I can give you is a laboratory. So they're an order taker, and it just does not make any sense to have them be, have a VBP apply where you're asking them to take on some sort of care coordination and management role. But what you can do is you can have a value-based payment program that includes their claims where somebody else is in charge of the value of those services and whether or not they're appropriate and cost effective. And so that's what we do. So we have our primary care groups as an example that are taking risk on other people's claims.
Okay, and that explains why the numbers that you're showing are higher than what Summer showed when she was doing the all payers, all claims database, because my guess is that those laboratory services were falling under the non-value-based purchasing category, while you are including them because they are something that are being managed.
Yeah.
Okay, thank you. Makes sense.
Just to chime in with one other distinction to note, so the data that Summer shared was from 2020, which is the most recent published data in APAC. And our carriers today are sharing their 2021 updates, which per PEB and OEB contracts, they report to us every September. So there's also, just to note, a slight difference in the years in terms of what was reported in the previous presentation versus what carriers have.
Let's go to the next page. And I just wanted to point this out as well. So at MODA, we take a somewhat conservative approach in reporting this. So we have some large health systems. OHSU is an example. They have both hospital and primary care services. When we have a health system that's capitated for their primary care services, but they also provide a lot of other services, in our view, it's not really, it would be maybe a little bit misleading to say that that whole contract is a 4A contract because of the existence of capitation. I mean, in the OHSU example, just for put ballpark numbers out there, we spend over $200 million as a company at OHSU, but only 10 million or so of that is primary care services. The rest of it is hospital services and specialist services. And so what you're going to see when we do our reporting is that we are not putting all that entire OHSU contract as a 4A contract. I don't know what other carriers might do or what the APAC data might show. I just am saying that is why, we're not going to report it as that unless we feel like the 4A category is really a meaningful portion of the contract. Okay, so let's go to the next slide. And then these next two slides, I have one for OEB and one for PEB. So this is just a visual representation to scale on what portions of the total dollar spending have a VBP that applies or not. And so you can see that the relative size of those squares or those rectangles in there, excuse me, in my geometry, you can see how much is hospital, professional, and other in the columns, and then the different colors show what percentage of those have a VBP that applies. I'll also just take a moment because I know Mercer folks had a question about this. This doesn't exactly line up with the previous chart of numbers that I showed, and that has to do with a small difference in the question being asked and how we've evolved our primary care reporting. When we provided our transparency report, it was just, does a VBP exist or not in that contract? And that's how this page was designed. And the other page had more to do with the actual dollar amounts of the payments that went out. We're going to do a little bit more work to unify those in future reporting. But that's why the previous slide, the numbers would appear to be slightly lower than what's presented here. And if somebody has more detailed questions about that, I can answer that offline. But the idea basically, though, is that we do have the majority of our dollars that are covered by some sort of VBP for OEB and for PEB. And if we go to the next slide, you'll see that you won't see the boxes change that much for OEB versus PEB. One of the reasons that it has been high in 2021 was that we did have the CPC Plus program. Now that program's ended for 2022. It ended on December 31st, so you'll see some adjustments there in in next year's reporting. But that's where we are for just in terms of is there a VBP in the contract. Let's go to the next slide, and then I just wanted to mention, I mentioned behavioral health VBP, so we've introduced that. We're working on a number of ways to try to further increase not only the raw percentage of how many dollars are captured where we're paying for value instead of fee for service, but also the quality of those programs and the reach of those programs. And in our opinion, it's great even if we have multiple overlapping programs. We can, there's as long as all of these programs can have an impact on provider behavior, I think that there's a lot more room to introduce some more models. And so For the behavioral health one, we're looking, there's two approaches to this. One is to track and report outcomes measures on feedback-informed treatment, which is a behavioral health concept that's gaining some traction. And then also for some of our members that have severe and persistent behavioral health issues, these are people that regularly are receiving treatment year after year, multiple visits. We felt like there was an opportunity there to reward the care coordination that would be helpful for those people who often tend to have high medical costs as well as behavioral health costs, and those two work together. And so that incentive is going to apply as well, but it's going to be a subset of people who use behavioral health services. It's not going to apply to every single member. Whereas the outcomes measures, the intent there is that this is just we're helping provide an incentive for our providers to provide a data-driven and tracked treatment for their whole panel. And on this one, just for administrative reasons, just to make this, at least initially, we're going out with a 50-member minimum size, so that, and we do have a very large network of behavioral health providers, but not all of them have a significant enough members where it would be worthwhile to be tracking it. And let's go to the next slide. And then this is the only the other one that I wanted to focus on. I think after this one, I'll go through the next ones probably pretty quickly. But we are introducing a health equity measure as well. And so there's been a lot of discussion about how to measure health equity and what to do. And this lays out sort of the approach that we're thinking of. And we've done a lot of talking with other folks in the industry and just internally thinking about what data we have and how we might measure this. But what this slide is just showing is on the left there, what would we measure? And then on the right, what would be the ways that we might measure it. And so in terms of what to measure, just given the fact that that we don't have large, what I would say as we have a large white population in Oregon, just to put that out there, and the number of minorities is small enough that makes measuring small groups of members difficult. And so in order to have a good measure, that measure ideally would have a lot of credibility based on a large sample size. And so we feel like what we can do is carefully select some high utilization, high volume services where we have enough data to get a credible result. And an example of that would be office visits or perhaps prescriptions, where there's just many of those. And so you have a big enough data set that you could be measuring that with some credibility. And then similar with quality measures, target some of the quality measures that have large denominators, so that even though your population of minorities might be small, you'd still get a credible result in the measurement. And then what we're focusing on also is metrics with large disparities. So we've looked at some of these things in the past, and I'll just give you an example. This is an example that applies to our Medicaid business, but there's other similar examples from Portland, from commercial. And that is that we noticed in primary care, when you look at the utilization of different racial and ethnic groups as an example, there was not a huge disparity in terms of how much care people were getting. But yet, when we looked at referrals to specialists and downstream services, that's where the disparity became magnified. And so when we have an opportunity to decide what are we going to measure in terms of is there a disparity or not, we'll pick the ones that we feel like have an existing disparity that we can track over time and measure how well we do to reduce that disparity. And then just a couple of things just to flip to the other side of the slide in terms of how we would measure it. This is just through trial and error. We've come up with a way that we feel like we can use some normalization that does not have a pre-existing bias. For folks who've spent time researching and thinking about this topic, it's pretty well understood that a lot of the risk adjustment algorithms used today, they have some inherent bias built into them. So the way they work is that they often are looking at utilization to pick up diagnosis codes as an indication of how sick somebody is. But if there is a pattern that there's barriers to access for certain groups, then that's going to depress their risk scores, that if the risk score is based on diagnoses. And so it's sort of a circular problem there that we're going to try to avoid by using measures that do not have that potential for bias. And then I mentioned just the concept of using pools, to try to aggregate as much as possible some of the data so that we can have really good, credible results. Anyway, so this is just some work that we've been doing on health equity that we plan to roll out for 2023, so that we can enhance the existing value-based payment models that we have in place now.
Okay, Bill, I'd appreciate it if you could do all you can to help us finish.
I didn't quite understand.
Edit the balance of your presentation, please.
Sure. Yeah. Well, then, in fact, I don't need to. I wanted to put the next few slides in there just for reference, but I didn't intend to spend much time on them. In fact, we can stop there, just in the interest of time.
Great. Thank you very much.
Yeah.
Any parting questions for Moda? I don't see any hands raised, so we can move on to Providence. Thank you.
Hi, can you hear me okay?
We can. You sound good. Yes.
Oh, thank you. Well, I'm Stephanie Dreyfus. I manage our provider contracting and provider relations area for Providence Health Plan, and I have presented to you before, so appreciate the opportunity again. I will not take a lot of time. This, I converted this into percentages. I just wanted to go through this, the kind of the grid that we were asked to complete. On the hospital side, we do not have value-based payments. As I've presented before, prior to 1076, we actually had quite a few value-based payments with our hospitals for the PEB population, but with the once SB 1076 passed and they weren't able to be paid more than 200% and weren't interested in taking downside risk. So right now we do not have any hospital, and this is true even in 2022. On the professional side, and I will talk about this kind of throughout the presentation, most of our value-based payment, and really all of it for PEB, is in our quality pay for performance. This program is designed with a withhold, so it does have downside because the providers are putting their fee for service rates at risk. It is a limited, you can see it averages 2, it probably is as high as 4 for some groups, but they're really the downside risk and the focus of the value-based payment has been around our quality program. We've presented it before. It's a very robust program with substantial kind of technical resources and data sharing at the plan level. And we continue to look at those metrics every year. And about 30% of the dollars go through a contract that has a value-based payment component to it. And of those, about 45%, and this is just for calendar year 2021, 45% of the withhold was returned. So a little less than half of it. And what it means is that all of the metrics were not achieved in all of our contracts to get the full withhold back. Okay, next slide. I just wanted to highlight again that, although they don't really, they're for sure not a land through category, we have for a long time made payments outside of fee for service that groups have used for care management or for infrastructure development. So for all of our medical homes, we're in the PEP Choice Network, we do pay a care management fee, a PMPM. We also participated in CPCI and CPC before that for the full 9 years. And coming out of that, it was sunsetted at the end of 21. But we did offer what we're calling a bridge program in 2022, so that that PMPM payment that groups had really utilized to hire different kinds of staffing levels didn't just get yanked out from under them because the decision was made pretty late in the year. We are transitioning that program to a new program in 2023, but we have continued to pay those through 2022. I talked a little bit about the pay for performance. PEB makes a payment. We do on behalf of PEB a PMPM to any group that is not a medical home, but is PCPCH for their attributed PEB lives. So it's less than the medical home, but we are making a payment. And then we do for behavioral health, we actually do this kind of with physical therapy, is that for our behavioral health program, our concierge program, we actually, it's like a capitation. It's an episodic capitation. So they are paid per episode for a certain treatment time period. And so really it's one of our specialty capitation that has worked really well. Okay, next slide.
Hey, Stephanie, very quickly, this is Cash. Is
Hi,
your
Kat.
is your camera hi, is your camera on? All I see is a green screen.
Oh, do you not see me?
I do.
I
Sorry.
can see her.
I can
Oh,
see
there
you fine.
you are.
You were a green screen
you-
before, but you look fine now. So, and I think
Okay,
it looks
perfect.
like,
Now,
yeah,
okay,
you look.
okay. Thank you. Let me know if you can't see me any longer. So I wanted to talk a little bit about 2021 and kind of the decisions we made. So as I talked about with, with the hospitals, kind of the risk sharing we had with them sunsetting, we really did not want to go implement shared savings only with, and you've heard and you'll continue to hear that, particularly in 2021, it was a difficult time, but it remains a difficult time for providers to consider downside risk. And had we implemented upside only, really mostly because of just conditions around the pandemic, I am sure there would have been surplus shared. And you all know what your trends were during the pandemic. And we really felt like that would have a short-term cost to PEB without really rewarding, what we all hope value-based payments will really reward and incent, which is, a sustainable change. And so in 2021, we did not do shared savings only. Again, the baselines were unpredictable. And most of the change in total cost of care was probably more related to the pandemic than really any systematic changes. And so we did not put shared savings. And I believe that in 2021, and I think this continues to be a challenge, we could have put in shared savings with a lot of primary care groups on top of their fee for service, but that the ability to really move to a downside model was simply not there. We did, during the pandemic, though, work really hard with providers to try to figure out strategies to continue to focus on the quality metrics, even when they had more limited face-to-face. We really worked closely with them through telehealth to try to help them continue to not just kind of put quality aside and give up on it, but to really try through the pandemic to be able to continue to focus on it. Okay, next slide. I did want to spend, and again, I shared this slide with you all in April, and we are completely aligned, about needing to move away from a pure fee-for-service model, whether it's primary care capitation with shared risk, including, incentives around quality, There are some things in fee-for-service that we believe are innovative and should not be thrown out simply because they're fee-for-service. And these are two good examples of that we are paying for e-consults between primary care and specialists. This has become, the uptick has not been as great or as fast as we hoped, but we're continuing to work to figure out how to increase the uptick, because with the shortage and the capacity constraints of specialists, anything we can do to get a member the care they need without having to maybe re-refer to a specialist is going to be really helpful. And it's probably, it does help total cost of care, but it's really more about getting patients the care they need in our capacity constraint environment. And then the other one is similar, but on the BH side, to really help primary care continue to be able to care for their patients, given, again, the extremely capacity constrained mental health system we have, and particularly with psychiatry. And again, I think we have put the mechanism in place to pay for them, and we just need to continue to work to help providers get this into their workflow. Okay, next slide. So I just wanted to talk, again, this is, I shared some of this in April, and you are all going to be very familiar with this. But I would say, we talked a little bit about the barriers on the hospital side and ASO groups. We are still, we take the mission to work to implement value-based seriously, but we also understand that we need to do it with downside. And providers have not and continue to really be in a difficult place to consider taking downside risk. We also understand that it's really hard for most primary care groups, or most any groups, to operate in multiple models. And you heard before we all started presented, you heard from the value-based collaborative, who has brought together payers and providers, really with several aims in mind, but one of them is to try to develop a similar enough model that, particularly for small practices, that they actually could support standing up the infrastructure, because they're not managing 25 different quality metrics or 15 different capitation lists. So that they really can. And honestly, although the results of CPC were not what we all hoped for, the theory of having kind of all the payers, including fee-for-service Medicare, collaborating on a similar model was really successful, and I think helpful to the practices. And we also, I would say 2022 is not, is still, we are continuing, I think, a little bit unpredictability of baseline, simply considering the resource and the workforce shortages that are really impacting care right now. And I think I have one more slide. So looking into 2023, we will continue to focus on enriching and expanding our quality pay for performance. We are looking to start to add member experience metrics into the quality pay for performance. We're also starting to introduce a separate member experience program, because member experience has, not that it hasn't always been a focus, but as many of you know, on the STAR side for Medicare, it's become a much bigger percentage of the total scores. And we absolutely agree that it needs to be a major focus in addition to quality and total cost of care. So we are starting to introduce a member experience program in 2023, and we'll look to expand that in 2024. As we work with all of our medical groups, we are looking for opportunities to implement total cost of care or some kind of risk sharing that includes downside. I will not lie, it is really challenging. And it is, in the hyperinflation, it's become, I would say, probably more challenging. But we are certainly, having those conversations with all of our large medical group negotiations. And then lastly, again, back to the conversation you had before, We are participating in the OHA value-based model development work. We do understand the need, again, particularly for the smaller primary care practices, to have a model that is more consistent across payers. And so we hope through that model, there will be some things that can be in the future rolled out that will accelerate value-based in a meaningful way. Okay. Any questions?
Yeah, this is Sean. I have a quick question. Well, I don't know if it's quick. I have a question. From your point of view, thinking about the providers, do you feel that it's more advantageous sort of naturally for a provider to be in a fee for service arrangement versus a upside downside value-based payment arrangement, or the other way around?
So I think so cut me off anytime that you guys want to take a break. But I would say where value-based payments have worked really well, I can say in the Providence experience, is on Medicare and Medicaid. There is absolutely set and transparent funding. There are limited plan designs. In our products anyway, everybody is assigned to a PCP, so they know who they are assigned to. And those models, I think it's worked really well. And most providers would say it's not pure, they do get a fee for service payment, but they absolutely, count on the value-based payment as a major part of the package. And it's worked really well. And we've had those in place for many, many years. And it's, I think on the commercial side, it is so much more complicated. You have thousands of plan designs. Most of the members are not assigned, they're attributed, which is very complicated, much more complicated. The rates are all over the place. So I think on the there's not the concentration of membership because it's spread across so many payers. So I think on the commercial side, I think providers, and so I shouldn't speak for them because I've never worked on the provider side. But I think there is way more comfort in fee for service. They know exactly what they're going to pay for what they do. They can control it. There's nothing about attribution. So I think on the commercial side, even for some of the larger groups, it is a way harder leap into a value-based payment on the commercial side. I do think if we had, this isn't to be anti-competitive, but I think if we were a market like Massachusetts, let's say, or other markets where there were fewer payers and the volume was really concentrated and there was a lot of assigned lives, I think it would be an easier transition. But Oregon's a really fragmented market with a lot of payers. And I think that makes it, I think it just makes it more difficult. So I guess, in summary, I'd say on the commercial side, I'd say their natural comfort zone is fee for service. Maybe primary care capitation because they can kind of get their hands around it. But being at risk for total cost of care feels like they're at risk for a lot of things out of their control. I don't know if anybody else would.
Any other questions? Okay, well, we're scheduled to take a break at this point. Let's make it 5 minutes so we can get back.
Sorry.
No. Thank you, Stephanie. We appreciate your presentation.
Right, so we're back at 3:07. I will put that in the chat.
Great, thank you. Okay. Let's reconvene and move on to Center of Excellence, report from our consultants at Mercer.
Thanks, Jeff. Rose, if you'd like to go to the agenda slide. So today we wanted to provide an overview of the where we're at with the multi-year strategy and the timeline. Talk a little bit more in depth about benefit design, potential benefit design to support the COE program, as well as travel benefits, just the types of travel benefits that we see, and get started kind of discussing that if we need to provide travel benefits, and then just briefly touch on next steps. You can, yep. So just to kind of level set, I wanted to just remind everyone that we have kind of revised our focus for our year one implementation. So originally we wanted to look at both facility and provider level quality, but given the timing and you know, the collecting the data and everything, what we've decided to do is to kind of reset and focus on facilities in the first year of the COE program. So really looking at facility level quality, identifying those high performing facilities in each region, making sure that we have adequate coverage, those types of things. And then as we advance through the program in future years, we can come back and add in that provider layer on top of the facility. And so I just wanted to make sure that we were clear for everyone that with the focus on facility level quality, any surgeon who performs these joint replacement surgeries at that facility would be grandfathered in for year one. So they would all be part of the higher tier, high quality provider network. Any questions on that? Okay. Can we go to the next slide, Ruth?
My only comment is, this is Tom, that I agree with this entirely, and that what it does is that it puts the focus onto the facility to start managing their own surgeons, because if they have people who are causing issues and dropping them out of the, you know, the tier one, the incentive is to fix that.
Definitely. Thank you, Tom. So there's a lot of words on here, so I won't go through every single bullet, obviously, but again, the year one timeline is that focus on facility quality status. For October, we are currently continuing to collect facility level data from the carriers, and they've been providing us with that. We're pulling all of the data into a single source of truth so that we have the most comprehensive data that we can to sort of identify those high performing facilities. The plan is that next month we would come back to this group, hopefully with an overview of the facility results, including any potential gaps in any one region. So we want to make sure that, you know, when we're looking at the quality, do we have adequate coverage across the state in each region? Are there individuals who would potentially need to travel in order to, you know, have care with a tier one or tier two provider, those kinds of things, so that we can make sure if there are any kind of barriers to the success of the program, we can start to think about how we address that. In addition, next month, we would like to finalize the recommendations for the IWG to present to the OEB and PEB boards, either in December or in January. So really start to laser in on that recommendation around plan design, potential travel benefits, and the approach with facility and network quality. And then in December, the IWG will present those recommendations to the OEB and PEP boards. And hopefully we can help them move toward making a vote on whether they'd like to move forward with the program for each of them. Oh, sorry. And then once those decisions are made, in Q1 of 2023, we would work with the carriers to start really negotiating with those tier one providers that have been identified, and also to build out the member support infrastructure that's going to be needed to support the COE program. So, you know, assistance to help members identify a tier 1 or tier 2 provider, to get records transferred if that's needed, to set up travel benefits, you know, all of those kinds of things. So really start to work with the carriers to define how that's going to be delivered and who's going to deliver it. Then in Q2 of 2023, we would want to be finalizing those contracting efforts and the member support programs, developing and launching communication plans, working with IWG and the carriers to develop reporting that will support us. So monthly and quarterly reporting for activity within the COE network, those types of things. And then in the program would go live for OEB if they vote to move forward in Q4 of 2023, so October 2023. And for PEB, if they vote to move forward, it would start in Q1 of 2024, 1/1/24. Any thoughts or questions on the timeline?
This is Tom again. The question that I have is, what type of communication strategy do we need to have with number one, the hospital association, and number two, the facilities in the state where this is, where we're looking at doing this? Obviously, both of those groups of entities know about it because we've been asking for data. So they know that we're looking at it, but my only additional thought is a communication strategy around for the facilities, and having some communication with the hospital association. So, and even God, if we could get their endorsement, it'd be even that much better. But an understanding of because this is not the only area that we're going to be pursuing centers of excellence. My guess is that we're going to be, if we're able to pull this off, it may be a strategy that moves throughout various delivery aspects, healthcare delivery aspects.
Yes, that's a great point, Tom, and we are working with the carriers, and our plan is to sort of work through the carriers in terms of the communication process.
Yeah, and I can put together a memo, Tom, when the timing's right, to the hospital association, kind of explain the program and what we're trying to accomplish.
Yeah, that would be, I think it would be sooner rather than later. I mean, I think that definitely they probably should the hospital association probably should have an ability to provide public comment at the board meetings that we're going to be discussing this, instead of it being just a fait accompli. That's just a thought. I'm obviously not driving that decision, but whatever we can get in terms of agreement and cooperation with this at all levels of the healthcare industry, it will be very helpful.
Yeah.
Okay, thanks.
Any other questions or thoughts on kind of the next 12 to 18 months? Okay, we can jump to the next slide, Rose. So we did want to kind of lay out a draft multi-year strategy and timeline. So looking at the next 1 to 5 years for the COE program, should we decide to launch it, how, you know, how's that going to look and how are we going to evolve it over time? And so in year 1, you know, the program would implement, we would work to develop a strategy and a way to evaluate the outcomes of the COE program. So, you know, it's great to look at reporting around activity, those types of things, but we really want to be able to measure the impact of the program so we can identify opportunities for improvement, that type of thing. So we would focus very heavily on developing that evaluation strategy in year one. We would also continue on an annual basis, so year one and beyond, to continue to collect data from the carriers, from our Clarify database, potentially from APAC. So as many sources as possible, we would continue to collect that quality data each year and then reevaluate. I'm sorry, Jeff, did you say something? No? Okay. Reevaluate sort of that tier assignment. So looking at, moving facilities up or down in the tier assignment based on their performance year over year. So we would definitely be doing that. In year one, again, focused mainly on facilities. Moving into year two, we would launch that measurement strategy. And then we would also start to look at provider data in addition to facility data. So pulling in all of that provider quality data, again, from the carriers, from the providers themselves, from APAC or Clarify, and start to assign those providers within the high quality facilities into sort of those tiers as well. So then hopefully we would be able to move into, by year three, a strategy that incorporates not only facility quality, but also providers within the facility. And Tom, to your point, it gives our facilities a couple of years to sort of identify if there are any providers that need to work on quality improvement in order to qualify for the program.
Cindy, I'm having a little bit of trouble hearing you on your microphone, whatever. But in year two, could you elaborate on what you meant on communication plans developed? Because we're starting that in year one. So what's the refinement that is in the year two plan?
Yeah, so the plan would be to move in year three to a program that includes both facility and surgeon quality. So we would need to develop the communications to transition the plan from, as long as you go to this facility, that's a tier one facility, then that's in compliance. By year three, we'd like to say you go to this high quality facility and you utilize one of these high quality physicians to get the highest benefit.
Yeah, so Jeff, it would be, so it's assuming that we are launching with providers as well.
Yes.
Year three. So the communication plan that will be developed in year two would be to incorporate that facility provider matrix for the COE.
Okay. Thinking a little bit about how you get feedback to the providers so they know where they stand and what the concerns are. Where is that?
I don't have that completely, I don't have that outlined in here, but I can definitely add that in. That would be our process in year two as we identify high performing providers.
Yeah, and I think it's mentioned a little bit in year one, but we can elaborate on that. But go ahead, Tom.
Yeah, I would just, I'm looking at year three where it says consider expanding program to include additional procedures. I would move that to year two with then having at year three essentially deciding to expand it, because I think the financial pressures are going to be on both OEB and PEB to do things that make a difference, not 5 years down the way, but several years. And the consideration process is all that data collection that it's taken us a year. So I would, again, move that consideration, the IWG saying, yes, these are the next 2 or 3 procedures that we want to look at, and then making a decision the subsequent year. Small refinement to your, what you're saying there.
I agree, and we might even want to say based on the volume that we have and maybe even the volume in the state, which one we might do first. So there's a progression. The next one is spine, and the year after that, or
cardiac or something.
We're looking at cardiac. And part of the purpose of that is communicating to the members that we're beginning a progression of refinements in the program.
Yeah.
But yes, this is a nice first draft, so to speak.
Absolutely.
Yeah, what I asked for. Thank you.
That's helpful for us as well, Tom and Jeff, so we can backtrack, those activities that we would need, if we're starting to consider spines in year 2 and whatever, then we need to start preparing, then collecting the data that would be needed to make the determination and step, just the steps needed for that. So we'll update the timeline. Thank you.
Yep, for sure. One of the other things that we had in year 3 was to start thinking about looking at bundled pricing and warranties, just seeing the impact over the first 2 years on, the ability to improve utilization and improve outcomes. Then hopefully we would be able to move on to start thinking about, are we able to negotiate some favorable bundled pricing and associated warranties to go with that. And then in years 4+, we would just continue that annual, evaluation of outcomes, continue to consider additional conditions, each year collect data, revise the tiered listing, and could even consider, in future years, removing tier 3, for example. So for coverage of certain procedures, you would need to see a tier 1 or a tier 2 provider. So those are things we can consider, levers to think about pulling in future years. Any other thoughts or comments? We can definitely revise this and get a revised version back out to you all pretty quickly.
Yeah, thank you. Ready to go to the next page?
And this is for Ali. The only my worry is that there's winners and losers in this, and whether or not what the losers are going to be doing. And so I don't know whether or not it complicates things, but at some point in time, it probably makes sense to have regulators either in the insurance division or in DOJ to look at this and make sure that we're able to do what we're proposing.
Yeah, absolutely.
And having that done ahead of time as compared to, having a big blow up and then saying, well, we'll go check with people.
Right.
Well, Tom,
like
I appreciate
yeah. Oh, sorry. Go ahead.
Sorry. Tom, I appreciate putting the pressure on the facilities to play a role in managing the quality here. I think we might want to spend a little more time discussing how we would promote that.
Okay.
Yeah. Sorry, Ali, go.
Oh, no, I was just going to say, I think giving folks a chance to speak up before the boards make a decision might present a little bit of timing issues, but yeah, we'll huddle as a team and see what we can come up with.
Yeah. Okay. Moving on.
Hey, Rose, if you want to go to the next. I think I'm going to hand over to Emery, and he's going to talk a little bit more about benefit design.
Thank you, Cindy. So what we're showing here is slightly refined version of the benefit design that was presented by Kirsten during the prior meeting. The general gist of the plan design remains the same, where we have 3 tiers. The one tier 1, the center, the bullseye, where they meet the quality standards. In addition, they would agree to additional contracting terms to improve quality. So maybe warranties or things like that. For people who would go to those facilities, the additional cost tier copay would be waived. So that'd be savings $500 for each of those members. And also, we were proposing that travel and lodging would be possible for those who would travel to those tier 1 facilities to get the services. So essentially help defray some of the costs, especially if they have to go out of region. We are going to talk a little bit more about travel and lodging, but try to, I guess, consider which facilities you'd want to have that travel and lodging, or, the types of regions, if there's not enough facilities in a certain place. Keep that in mind as we discuss this plan design. For tier 2, this would essentially be those facilities, that currently are in network that meet the quality standard, but did not agree to traditional contracting terms. The benefit design would be the same as they currently have. And then I guess that third bullet there under the tier facilities is, again, something to consider about travel and lodging. So while we may not end up in a situation, but there could be the situation where some regions have very few facilities, and for whatever reason, those facilities don't qualify, as a tier 1 or tier 2. So in that case, would IWG, would the boards want to provide travel and lodging for members to go to a tier 2 facility that would be out of their region if they only have tier 3 facilities in their region? So that's one, I guess, area we can talk about in a sec to consider as we refine the plan design. And then the tier 3 facilities, these are those who don't meet the quality standards, the lower quality. So those facilities, as we presented last month, we originally said those might be out of network, but following conversations with the plans, contracting would probably make that very difficult to implement. So what we would do now would essentially do a 3-tier in-network. So tier 3 facilities would still remain in-network, but we would essentially increase the copay, or the additional cost tier copay. So instead of paying $500, we would increase it up to about $2,500 to kind of almost mimic the cost sharing if you did go out of network in this case. For these tier 3 facilities, we would not want to allow travel and lodging for members who would go to those places. So that's our proposed plan design. I think there's a couple of areas where I'd like to welcome comments. One is around the additional cost tier, the copays that are associated with these tiers, just confirming the levels and that IWG members feel comfortable with them. And then the second one would really be about the travel and lodging. I think generally we would probably want to provide travel and lodging for those who go to tier 1 facilities, and then tier 2 facilities, and whether you want to just have it for those who don't have a tier 3, only have tier 3 in your region, or I don't know, just confirming that, or if you don't even want to have tier 2 travel and lodging in this case. But I welcome your thoughts.
So I have a question. I'm in favor of an additional cost here. I'm just wondering, on making it 5 times as much, how that interacts with health equity. That's not my forte there. So I'm just wondering what consideration was given on triangulating with that.
Yeah, well, that's definitely a concern with the pricing. In terms of running it through the tool, I don't know how the tool would say on that. I think we are trying to incent people to go to the higher quality facilities and make it less costly for them. And so in terms of equity, in terms of equity, there are ways to get lower cost savings, but the time and effort to get to those facilities, it may be more onerous as a result. So we'll have to definitely
Jeff, we
consider that.
talked about the importance of having a really robust travel benefit as a way of
Right.
addressing potential equity concerns, and in our minds, making sure that the travel benefit is designed thoughtfully, especially with those members in mind who might live in a tier 3 region only, will allow us to move forward with the quality aspect of the COE and still address the equity concerns.
Yeah.
It's going to have to be proven in communication, or at least given some examples. So,
And I think this is one that we need to bring to. We have a health equity committee,
Yeah.
so let's have the IWG send this to that committee to discuss and look into the implications, and you know, because the issues are: do you get paid for your work? Do you you know, it's various types of leaves that are important, and it's the as Kirsten, as you're saying, the richness of the travel benefit and the like. I would like to jump in and address. I agree with what Jeff just said. The idea of the 3 tiers, I think, are appropriate. The issue around the travel benefit, I guess, you know, it's if there were only if 25% of the current facilities are tier 1, I would, under the tier 2 facility issue, I would probably recommend having people where they're in a region that doesn't have tier 1 or tier 2. I would have either of the two. If we're at a situation where 50% of our total facilities fall under tier 1, they're going to be distributed enough that I'd be fine with it. The travel benefit only for tier 1 for those who live in regions where there isn't a tier 1 or a tier 2. That would be how I would approach it. I just don't know how it falls out yet.
Yeah.
I feel the same way. Yeah, I'd like to see where the tier 1s are before we determine that.
Yeah.
Yeah, and this is Sean. I agree with that, because we also, just an additional layer that we've talked about before, which is that we wanted to ensure that tier 1s could absorb the amount of work that we have. So we need to know. We also need to know their availability, not just their distribution. Like if they're already mostly at capacity right now, because everyone, you know, other people already know that they're good. Then that doesn't do us a whole lot of good, really. So, you know, we really need to take a look at that before we go, you know, a lot further. I would be inclined to have the travel benefit mostly aimed at the tier 1s, if there's a reasonable distribution, you know, somewhat. I know that they're traveling, that's the point. So I'm not trying to be, I want them everywhere in every corner. I'm just saying, you know, if there's a little distribution, that would be nice. And then more for me is like, do they have availability? Like if they already have a wait list out the door, then you know, we may need to think about this.
Maybe what we can do then, in the interest of continuing to move this forward, is we can have sort of like an if-then scenario to vote on, because you know, who becomes a tier 1 provider is actually mostly up to the provider. And until we get through the contracting process and have all these conversations and try to recruit into the tier 1 network, we won't know exactly who's in and where they're distributed, and won't have a whole lot of influence other than, you know, of course, relationship and political influence to bring them in at this point. So we can, you know, to Tom's point, kind of set things up where scenario 1, we have this coverage level, this is what we'll do. Scenario 2, with this coverage level in tier 1, this is what we'll do. So we could vote ahead of time on the options and then know exactly where we're going to go once the contracting is all finalized.
To address the issue of capacity, where we may, let's say we end up with I'm going to guess a number, 40% of the people, of the entities now doing these procedures are tier 1 and you'd think, oh, that may be a problem. But those 40% may be already doing 80% of the procedures. So it's the percentage of facilities that fall under tier 1, but then also looking at what's the current percentage of cases that those tier 1 people are doing. Because my guess is that if you had 40% of the facilities made it into tier 1, because volume is something that we're paying attention to, my guess is that maybe 80% of the procedures were being done at that 40% of the facilities. Just something to make sure we look at.
Yeah, for sure. Noted.
Thank you. Are there any other comments before we move on to the next slide?
Keep going.
Okay. All right. So one thing we wanted to just bring up is, this isn't, as mentioned, on the prior slides, talking about looking at quality. We're going to be doing that consistently. It's going to be it's a cycle where we're starting out right now in the north, in the top. I guess 11 degrees or 11 o'clock, with the benefit design, communication, travel, leisure, travel and lodging. We're talking about that. And then, as we move through the process and the members start getting the joint procedures, we're going to get more data, and we're going to take that and we're going to collect all the data, take a look at the facilities, and we're going to benchmark that and make sure that we have the right facilities there. And then as we do that, the process, we will tighten up and take a look at this, and then potentially moving on to other COE categories as well. Doing this entire cycle and consistently refining the process in this case. Moving on to the next slide. So some other benefit considerations with the COE is mentioned earlier about bundled payment with provider reimbursement. There is some of that going on right now in terms of provider reimbursement. If we can, requiring the providers to have warranties in case there are, unfortunate surgeries that didn't go quite as planned and they may need to be redone. So making sure that's not paid for, and making sure that the quality, the return or improvement of function happens for the members there. The types of COE services, we had talked about that as well, and as well as taking another look at the member incentives. We're talking, discussing the potential additional cost tier copays and how that might influence, whether it meets health equity or how that influences people's decisions to use those services as well. So I think we'll want to definitely take a look at that and measure it and see the impacts of, how are we shifting people, and are they shifting to the right facilities? Are enough people going to tier 1, or more people going to tier 1 as a result of the benefits or the copays? And that's maybe through surveys or just actual results. Are they understanding the benefits and following through and achieving the results we want to achieve with the COE? So those are some of the considerations to as we move on in this cycle, and then moving on. A few other considerations here. Member advocacy, I think trying to make sure, while communications, with the members and making sure they understand it, creating a robust member advocacy where it helps the members, makes it easier, helps them with the decision making, whether they actually need surgery or, getting them to that tier 1, like having that communication and that customer service to get them there, I think is key. And also trying to potentially stave off those surgeries that maybe aren't needed, and you can get the savings that way. The quality portal for members to take a look at. The COA network, how that might vary by carrier. Not all carriers are probably going to contract with all facilities, and so if, let's just say, for example, Providence facilities or OHSU being in MODA and Providence, whether those are actually they probably aren't going to be in each other's networks, at least for Providence Choice, so So there may be some COE network differences that will show up because facilities aren't contracted, and just making sure everyone's comfortable with that and the communications going on with that. Enhanced travel and lodging. We'll talk a little bit more about the travel and lodging benefit, but there are ways to incent people, like more incentives for people to maybe go to tier 1 by increasing that travel and lodging to make it easier for them. New providers as they come in terms of facilities, or if we start looking at providers, we'll making sure we have a process in place for assessing who's qualified and as they come in. And then I think we did talk about potentially phasing out travel tier 2, so that would be in potential another consideration. Any comments on this slide?
All makes sense.
Great. Like to hear that. Okay, so moving on to the next slide. We're actually going to talk about travel benefits, and I think I'm turning this back over to Cindy.
I think so. Yep. Okay, thank you. So we wanted to just provide some information for the IWG around what we see typically included in travel benefits and how they're covered. So, thinking about their, for some clients, members would need to fly, across the country, but for you all, most people would likely be driving, right, from one region to another to get to a tier 1 or a tier 1 provider. So reimbursements for driving to the facility, most of the plans that we see use 100 miles as kind of the minimum for being eligible for driving reimbursements. Some employers use 60. I do have a client that uses 60. And the way that it works is usually either a stipend. So if you're going to be driving, there's a certain amount that you get in a stipend to cover everything, gas, mileage, all of that, or reimbursement based on mileage, which is a little bit more to administer, right? Because it's not just, hey, they're going to travel, so we'll load a card with this stipend. You have to actually collect the receipts. Somebody has to calculate what the reimbursement is. So just a little bit more administratively that way. Driving reimbursements, either mileage or the stipend, are both taxable. So that is something that we need to keep in mind, that you're going to need to get a report on all of the monies that were provided as part of the travel benefit, so that that can be applied to folks' W-2 in terms of their income for the year. Other things that we see in terms of travel and lodging benefits are parking fees. They, again, can be receipt-based reimbursement or providing a stipend, a certain amount per day, whatever the average cost for parking is at hotels or in the area for you guys. Again, going to be fully taxable. Hotels, the IRS rule does cover $50 per person per day for medical travel. So both the patient and the caregiver, you would get $50 per day for each person. The one thing to remember, though, is that this only applies to the patient if they're not inpatient. So if they go to have surgery and they end up being admitted, then the nights that they're actually in the hospital, you'd only get the $150 reimbursement for the caregiver. And then lastly, we wanted to just mention meals and sort of incidentals. So, meals or other purchases that need to be made throughout the stay. That can either be in total, so a certain stipend each day, for example, for both the member and the caregiver, or it can be a per person. Again, this can be receipt-based, so then you just would need to come up with a list of what types of expenses would be reimbursable, or you could provide a stipend per day. Again, this would be fully taxable. So the delivery method, the ones that are most common are either a prepaid debit card. So if you're using a stipend or a daily allowance, then kind of pre-loading a debit card and getting it to the member before they actually travel, so that they have that to, they don't have to spend anything out of their pocket. They can just use that prepaid debit card to cover those expenses. So obviously that's easiest for the member. And again, administratively, it's a little bit easier also for the carrier or whoever is handling your travel and lodging benefits. Or you can reimburse folks based on their receipts. So send them a check. Usually no taxes are withheld from the reimbursements or stipends. So that would just be added to the W-2 at the end of the year. I think I wanted to tell you something. Oh, typically the COE vendors, like if you had a carve-out vendor that was delivering this, would actually help members make their lodging arrangements, so their hotel room reservation, and that would get paid directly. So you'd still need to report that as taxable income, but you wouldn't need to load that, for example, on the card or reimburse it. When their travel arrangements were made, that would be paid in advance. So any questions on that? See Jeff shaking his head.
I mean, this is Tom. I think PEB with its having all state agencies would be easier to get the information to the people. The complexity of this for OEB with its over 200 entities, to give that information, to put it into people's payroll systems. Is it more than just income tax? Is it Social Security and everything else when you say fully taxable as income?
That's my understanding, is it just
Okay,
goes to your
that's it.
bottom line wages. Yep.
Yeah, it's a complex, and I wonder, I don't know, JJ, what are your thoughts about being an HR guy and having to put in your add to taxes for someone who's having a hip replacement and is traveling to Eugene?
I mean, it's pretty tricky because it depends upon how their finance system works on how it's going to work, and then all of that thing also opens it up to subject to collective bargaining. So it's a benefit change that would affect their pay. So all that stuff's really tricky.
Yeah,
But
we'll have
under
to do
this
some
proposal,
research.
who would be issuing the debit card or the money? It would be coming from OEB, wouldn't it?
Yeah, we'll definitely have to do some research here, because there's issues no matter which way you look at it.
Yeah. So I was shaking my head because I didn't have a question at the time, but at any rate, are there any other questions before we turn the page?
We found an area that requires a whole lot more work. That's all.
Right.
Yeah.
And I think Kirsten was going to speak to this slide, so I'll turn it over to her.
Hi, the goal of this slide was just to illustrate that there's more we can do. Cindy talked about the base travel benefit that we're seeing for our clients with the flight allowance or mileage reimbursement, lodging, and then potentially a meals allowance. But just, equity is definitely a concern here, as is OEB and PEB's desire to be a healthcare leader in the state of Oregon and do kind of more than the baseline. So these were just some ideas to illustrate potential services that we could add to a travel benefit. Again, sounds like we're going to be sort of kicking off now a separate work stream to investigate how to operationally do that in consideration of taxes and collective bargaining and other factors. So we'd include things like this and other things, that we determine might be good adds for this particular population.
Yeah, I mean, I feel like this slide is a good slide to take with us to the equity group, because I was kind of withholding some comments related to that, such as, I mean, we're just needing to know about paid time off, how it works with different types of workers, like workers that are closer to hourly workers that have our benefits, can they just take off, or do they lose income? There's these kinds of questions. Translation services. And then the one I'm really thinking about, that's kind of not on here, but it's sort of hinted at, which is what happens if someone does not have a reliable vehicle? We all, many of us presume that everyone has a car, because we all have cars, but someone may not. And what then? And so traveling across the state without a vehicle, or not in a reliable vehicle, or one that's not safe anyway, that might be a different thing. Maybe all they have is a motorcycle, which is not appropriate maybe for post-surgery, knee surgery or something. So we just have to think through some of that. Like, what would you do? I think that sort of stuff would be pretty rare, but we might just think about like special situations, kind of some flexibility around special situations around travel or whatever. But I think we should just kind of take that over to the equity group and talk it through.
Yeah, it's a good idea. We've talked about lots of one-off scenarios too, Sean, including the one you mentioned where someone either maybe they can't drive for certain reasons, or they don't have a reliable vehicle, or they're just not even comfortable traveling a long distance by themselves. Some people don't like traveling at night, for example. So yeah, we'll take this to the Health Equity Committee and go from there.
Kristen, you might also think about if they don't have a caregiver, maybe they live alone, or
yeah,
we have someone who can travel.
Yeah, we had travel companion was on our list, and I'm sure there are many more that will come up in the Health Equity Committee. When we talked about this several times last week and this week as well, just in light of, we don't, like, these are important considerations to work through, and we want to approach it from the perspective of there is a solution to put in place that will allow us to move forward with prioritizing quality of providers, because that's, it's such a key priority in healthcare now, is to be able to look at things through a quality lens. So we need to be able to do things like the MSK COE, and then eventually other service type COE. So this is a really great first test case for us to work through all these questions and figure out how can we ensure equity and deal with taxes and all of these practical considerations. We'll figure it out this time and have it in place for all of our future endeavors.
One other thing, just a question to ask. I think the answer is that it's not an issue, but it's worth a question to DOJ, is if we have a potentially taxable benefit, will that affect the Oregon pay equity law? Is it allowable under Oregon pay equity?
Yeah, it's a great question, JJ. I've already started a list. I'll add that one for sure.
You'll also connect the dots between this travel benefit discussion and some other travel benefit discussions. I'm interested to know how the bariatric surgery travel benefits being implemented so far from MODA, just in terms of some of these operational questions we've been asking, like taxes. I know we're also talking about a travel benefit potentially related to the Roe versus Wade or transgender surgery. So these questions will all be relevant there as well. So we'll regroup to make sure we're connecting all the dots.
So I'd like to ask the question: is the work group generally in favor of an expanded or robust travel benefit? Is this going the right direction?
It is.
Yeah, I mean, I am.
Yeah.
I think we need to think about a robust one for making it usable, easier, and for equity concerns too.
Okay.
Yeah, I agree.
Yeah, I agree.
Is Kimberly still with us?
The hope is that we're going to get geographic spread in terms of the facilities that turn out to be tier 1.
Yeah.
But I think Ali has a van too, don't you, Ali? You could maybe drive people around. You don't have much to do these days.
Have you looked at gas prices lately?
No, you'd be reimbursed.
Okay.
We'd give you a gas card.
Well, good discussion. I think we really are going to need to have some kind of proposed facility list here pretty quick to help people get their arms around what's the potential is. So look forward to seeing that. I'm ready to call for public comment unless somebody's is dying to ask another question or make another comment. Okay. Rose?
No, there's no public comment.
Okay. Well, according to my clock, we're finishing with 2 minutes to spare. That
Look
wasn't
at you.
the published one. So there we go. I will close the meeting. It's
Thank you,
adjourned.
guys. Take care,
Bye.
everybody. Bye.
Bye-bye.
Thanks,